everyone. Welcome to Emerald Medicare's first 2025 webinar. I'm so glad to have you all here today. It is a pleasure to be able to continue the educational model that I believe I have built over almost a decade with Emerald Medicare and in this industry. It is a true pleasure to be in front of you through this webinar model today. I have a lot to cover, and I'm going to say up front that I hope you stick around to the end because we are rolling out some really advanced digital solutions that will not only be groundbreaking for you, but also for Emerald Medicare in our ability to support you with prescription drugs, keeping the most up-to-date information on you in our system, being able to manage any benefits and prescription drug changes, updates that you may have. So that's at the end. So it's a video, and so we'll go through that at the end. But there's a lot of information to cover. The only other thing that I'd like to cover is that I have lots of webinars on YouTube. And often I do Medicare 101, the basics. There will be a little bit of Medicare 101 basics in this presentation, but I'm also attempting to cover some really new areas of focus that I think are really important to understand about Medicare as we approach 2025, approach a new administration, prescription drug changes. For those of you who have been a part of my webinar series through the end of 2024, heading into 2025, a lot of changes occurred through the Inflation Reduction Act. And so I did my best to keep everyone up to date, and I will continue to do that through this year. So again, thank you for participating, and I'll start out with some of the basics of Medicare, and then move into some new and advanced ideas and education that I hope you value. So many of you know me, some of you don't. I've been in this industry a long time, 10 years with Emerald Medicare, but I go back a long time in healthcare, having trained thousands of people in rehab software. I ran a training company in healthcare for many years out of New Jersey. So I have a real passion for healthcare, and I really bring all of that to the table. I'm a CSA, which is a Certified Senior Advisor, so my breadth of experience and knowledge on many areas of senior care is really quite vast. But I'm an advisor to many groups of people, whether it be the individuals that I ultimately work with, but really financial planners, CPAs, social workers, case managers, medical office staff, HR folks. I really try to be a valuable resource to all of them. I've been involved as the president of the Financial Planning Association of Hudson Valley and a board member and a speaker for many chapters around the country. I've had the great opportunity of educating over 4,000 seniors and 2,000 trusted advisors. So I'm proud of that, but also I'm the sole independent resource for the local healthcare system where I live, and I'm very involved in my community. I give back a lot. I've had a radio show, and I'm proud of the background and experience that I bring. So there's so many questions. I say people shout from the rooftop with their concerns, their anxiety, their questions, their research on Medicare, whether it be Part A or Part B, or the timing, or penalties, or home health, or how does things like dental care get covered. And so I really aim to continue to educate, as does my wonderful staff. But healthcare costs are so important. They are a big part of people's financial plans. Again, I work with a lot of financial planners and CPAs. They often work with us because they know they want to be able to help their clients understand what the costs are going forward. Drug costs are very important. The single biggest area of anxiety throughout the year is drug costs, and we'll talk a lot about this in this presentation. But also dental concerns. We'll talk about that as well, but a lot of people don't choose to have dental coverage, but is a very important part of coverage as one gets older. Some healthcare statistics. The average cost of healthcare in America is around $11,000 per year per person. That's what it costs, but it's $4.5 trillion is spent on healthcare in the United States, eclipsing the gross domestic product of many third world countries. But surprisingly, 50% of all medical costs in America are pre-diabetic insulin care and medications. That's a huge cost, which is always being reviewed and evaluated by all administrations. But poverty and racism account for about 60% of all healthcare costs, which is why so many of these plans really look at how can they manage care, yes, control costs, but also make sure people are taking care of their health with preventative exams. 63% of people age 65 consider healthcare to be their number one concern. And most new and existing enrollees really worry that they'll get this important Medicare decision wrong. Up front, we encourage people to use an independent Medicare broker to really help them navigate. You know, Social Security increases happen every year. What they don't always talk about is the increases to Part B premiums. So over the last 30 years, Social Security has gone up, but so has Part B premiums as well. But there are notable Medicare changes that have occurred over the years. In 2023, the insulin cost cap was put in place to $35 per month to make these critical medications that are essential for so many people affordable. I hope that stays in place, but $35 has made a huge difference. Free recommended vaccines, right? Eliminated out-of-pocket costs for these vaccines recommended by the government, including shingles and pneumonia under Part D coverage. In 2024, they expanded the eligibility for Part D extra help. I'll talk about that more later, but it really is about broadening the income and resource limits so that more people qualify for low income for reduction of either premiums, deductible, or co-payments for prescription drugs. And then, of course, the negotiated drug prices, which hopefully will continue. 10 expensive Medicare drugs were targeted for 2025, and more will take effect in 2026. So those are all good things. 24% of Medicare beneficiaries use Medicare.gov. I will be speaking later about something called Blue Button, which if all of you or some of you engage in, you will be able to help us share your information so that we can actually get the best prescription drug plans for you as you work with us each and every year to check pricing, because there are significant increases and changes in your prescription drugs and all prescription drugs, but only 24% of people are using Medicare.gov. We hope to have more of our clients use that site through us. 30% of all Medicare clients are hospitalized to some extent each year. This is by far the largest expense for healthcare companies. That's why they want to manage your care, prevent hospitalization, have some kind of care coordinator involved. About 2.5 million people actually pass away each year. 74% of this country that have Med Advantage plans in their county have a zero premium plan. We'll talk more about that, but these zero premium plans for many people offer a tremendous opportunity for them to only pay copays for when they use the services. But even a 5% change in that premium makes a big impact on consumers. 80% of people who enroll in Medicare do so on their own without broker support. Again, 70% worry that they're going to get this Medicare decision wrong. But in year 2, many people start to use a broker. We encourage people to use a broker right up front. So Medicare is at the crossroads. The current administration has rescinded some of the last president's order extending ACA enrollment and funding for these plans. There's 24 million people who are getting subsidies that allow them to participate in the Affordable Care Act that helps them being able to afford health care in America under the age of 65. The future impact is uncertain. Medicare drug pricing reform. The current administration is rolling back some of the last president's policies to curb Medicare and Medicaid drug costs. I want to tell you that in 2025, roughly 160 million Americans relied on programs that CMS administers and oversees, including Medicare and Medicaid. 68 million seniors and people with disabilities rely on Medicare coverage for essential health care, including hospital visits, screenings for cancer, diabetes, depression, and prescription drugs. Nearly 80 million Americans rely on Medicaid, making it the largest public health insurance program in the United States. Medicare Advantage plans really offer comprehensive care for seniors. It offers benefits to promote healthy living, preventative care, and keep seniors healthier by lowering medical costs. So Medicare continues to negotiate drugs. They're targeting 15 drugs going into 25 and 26. Ozempic and Wegovy is included. But there are some federal grants and loans that are frozen. The administration is seeking to pause trillions in grants and loans to reassess federal spending that could affect healthcare. Health hospitals and providers are looking at these legal challenges because funding cuts could impact patient care a lot. So I wanted to cover that. But health insurance is different for everyone, depending on where you are with your current health, your current budget. People who are looking at their group coverage, their retirement coverage, that's one set of options. People who are not working, who are unemployed, self-employed, have another set of options to consider. It's really important that one looks at their premium costs as an employee or a spouse, or their savings on Medicare. I often look at the costs and the benefits summary of a particular plan. And I also want to know what the utilization of someone's plan is, whether it be themselves, their spouse, or their children, to truly look deep into the copays, the deductibles, and the out-of-pocket maximums. This is where the rubber meets the road, folks. Medicare has some of this depending on the plan. Copays, deductibles, and out-of-pocket maximums, especially the Advantage plans. But how does this transition from your group plan to retirement impact the timing of Medicare enrollment? That's what people often ask, whether it be Part A or Part B. There's timing issues, and people often have the information that are shared by their friends, their neighbors, their colleagues, and slightly incorrect. So at our company, we really do settle people into making sure they understand what the timing is. But these supplemental coverage, whatever one's adding to Part A and Part B, will vary by state and in some cases even by county. So I often tell people, call me 3 months before you move, 3 months before you turn 65, or 3 months before you retire, because that's when people want and need peace of mind that they're going in the right direction and they're not being confused by TV ads or mail that they get. Each year, we encourage every one of our clients to evaluate the coverage that they have to ensure that it's the best for them that fits their current budget and health. We are committed to that. Last year, we helped about 700 people through open enrollment. It was the biggest year ever, but because of the changes that occurred, that was the work we needed to do as a team. But is original Medicare automatic? Well, the answer is both yes and no. If you're collecting Social Security at age 65, you are automatically enrolled in A and B. You can decline Part B if you are already covered with a plan that you like through yourself or your spouse. But if you're collecting any kind of Social Security, disability, under age 62, under age 65, you are getting your A and B card. But A is premium free, but B is not. So many people don't realize that they can reject Part B, even though they're collecting Social Security, if they have a plan that suits their needs. So it's important to look at the plan that you have, how much you're paying for it, so that you can evaluate whether B plus a supplement works. And if you're not collecting Social Security at age 65, then Part A and or Part B is not automatic. Many people get Part A at age 65. They hear from their friends that if they don't do it, they get a penalty. Well, that's not true. But people do it. 75% of the people apply. My only comment on this webinar is that if you have a health savings account and you like your health savings account, you are not supposed to have Part A at all for 6 months before you get Medicare. Part A is, again, premium free, and there's no penalty for not getting it when you turn 65. Part B, on the other hand, is based on the size of the company that you work for or your spouse works for. So again, unemployed, self-employed, or working for a company of less than 20 employees, you need to get Part B at age 65. If you're working for a company of greater than 20 employees, you can choose to get Part B and either keep the supplement of the company, or you can go Part B and choose your own coverage. This is probably half of the phone calls we get every day is about the timing of A and B. So again, self-employed, unemployed, or working for a company of less than 20 employees, you need to apply for A and B. But what is Original Medicare? Original Medicare is A and B only. It covers 80% and it doesn't include drug coverage. Part A, premium free for anyone who's worked and their spouse or has worked for 40 quarters or 10 years, but it includes inpatient hospital care, skilled nursing, hospice care, and limited home health for someone who is homebound. It's Part A. Part B is not premium free. Part B is all the doctors, the specialists, the x-rays, the diagnostics, durable medical equipment. Part B is based on the tax return for you and or you and your spouse from 2 years prior. So in 2025, you're looking at 2023's tax return, essentially line 11 of your federal tax return, which is adjusted gross income. That is what they were looking at to determine the cost for Part B. What Original Care does not cover? It's a long list. A lot of these areas are actually covered by Medicare Advantage plans. Routine dental care, not covered. 24-hour care, nursing home care, there's a big gap there. Acupuncture, hearing aids, personal care. These are areas not covered by Original Medicare, but in some cases, limited, is covered by Original Medicare Advantage. So these enrollment periods that come up, this is where a lot of confusion lies. The initial enrollment period is that 7-month window, which is the 3 months before your birthday, the month of your birthday, and 3 months after. Again, people want to know the answer to this, but generally it applies most importantly to the people who are unemployed, self-employed, or working for a company of less than 20 employees. But you can get Part A. Again, if you're working for a larger company, you don't need to get anything else. But this is the initial enrollment period. The annual enrollment period is that period where TV ads, mail, everyone's talking about Medicare. It's October 15th through December 7th. This is when we're inundated with questions from clients who want to decide whether they want to stay with their plan or make a change. They have this time period to work with in order to change for a January 1st implementation date. Open enrollment period, we're actually still in it. And this period is where an individual on an Advantage plan can actually make a change to another Advantage plan without any questions asked. It's also a time when someone who's on an Advantage plan can switch back to Original Medicare and a Medigap plan. This is not a period of time that is talked about much by the carriers, but when we get calls for people who want to change or medical offices where people are not satisfied with the coverage they have, this time period allows us that change. The special enrollment period is the period often used for people who are losing their employer group coverage. So if they're retiring at whatever age, whatever month, They have what's called loss of employer coverage, special enrollment. So it doesn't matter what time of the year it is, we can switch them to their Medicare plan of their choice, helping them get Part A and B, or just Part B if they have Part A already. But that is one of special enrollment periods that exist. Another one that exists that is often used is people who are leaving their county or their state. They can have access to a special enrollment period. If they have extra help or low income subsidy, if they're eligible for dual plans, which are Medicare and Medicaid, often called dual special needs. There are also FEMA related special enrollments. We're talking hurricanes, fires, all of the things that happen in different states and different counties. There are special enrollments when people call us during the year. So if someone has Part A and they're retiring at age 69 and they say, I'm done, I want to go on to Medicare, I'm not getting any coverage, I don't have NISHIP or I don't have any program that's covering me for the rest of my life, I need to go on a Medicare program, I want to sign up for Part B. This is one of the two forms that need to be filled out. Medicare Part B, at the bottom in the remarks section is where we write requesting an effective date, let's call it July 1st. You sign this form. We help you by submitting this to the Social Security office. We fax it over there, plus one other form. This is the form that is filled out by the HR, the benefits department, someone at your company that verifies that you and or your spouse had credible coverage. These two forms are faxed to the Social Security office, and then you get the Part B effective date, the date in which you're requesting it, and then we move forward with whatever supplemental plan you are interested in. So there are four choices once you have Medicare A and B and you're retired. You can either stay on the employer group plan or the retiree plan, but I encourage people to look at the plan. Some people are getting subsidies from their employer. Some people stay on the employer group plan because they get extra benefits. Their spouse is on it, their kids are on it. Perfectly fine. I will help review that benefit summary, look at the copays, deductibles, and of course, is there a premium or is there not? So let's talk about it. Let's compare it to Medicare, whether that's the right choice. Original Medicare is 80% coverage, 20% you are exposed for. Original Medicare, as I mentioned earlier, does not include prescription drug coverage. The reason people like Original Medicare is because you can go to any doctor you want anywhere in the country that takes Medicare, but your exposure is 20%. But there are two other options, and this is where people sort of lean towards is one of these two. Option 3 is an Advantage plan. Again, there's a lot of bias against it, and there are a lot of people who love these plans. These are often zero premium plans. Maybe it's a $25 premium, but these plans are sort of pay as you go. Maybe a $10 copay or so for primary care, maybe $40 or so for a specialist, but then x-rays and diagnostic, you're paying a higher copay. Hospitalization and surgery are the largest costs for these plans. Each visit could cost between $1,000 and $2,000, but the premium is zero for people who are healthy. Often people look in this direction, and if they're looking to save money, and if they don't have much of a budget. There are a large percentage of Americans who are on Advantage plans, but they include some of the benefits that I spoke of earlier that Original Medicare does not have. Things like dental, eyeglasses, acupuncture, gym membership, other things like that that people want that Advantage plans have that the other option, number 4, does not. So number 4 is these Medigap plans. Some people call it Med Supplement, but it's really Medigap. These do not include a prescription drug plan, so one needs to add that as a standalone. Depending on the county you live and the medications you have, and I'll talk about more about that later, the premium on prescription drugs could be anywhere from $5 to $120 a month, depending on the meds. But the supplement plans, these are the best plans in America because you can, again, go to any doctor you want that takes Medicare anywhere in the country. You can travel from state to state. You're not in a network. 95% of all doctors in America take original Medicare. But depending on the state that you live in, you could be paying a premium of $90, or you could be paying a premium of over $350 per month per person. So this is, again, about health and budget. But these are the four options. Part B has a premium. And Part B premium, again, goes back to your 2 years ago, essentially modified adjusted gross income, but it's easier to look at the federal tax return adjusted gross income. If the income for a single person is under 106 or married filing jointly 212, then the cost is 185 per month. If you're collecting Social Security, it comes out of your Social Security check. If not, then it's a quarterly invoice, but you can convert it to a monthly premium if you like. But if you look at the chart, you see that as the income goes up, so does the Part B premium, and it's an income adjustment. And so does the Part D income adjustment go up. So people who are earning significant income in years before they retire look at this, and it's a little bit of a sticker shock. But this is the income adjustment that occurs. But there is good news. The good news is that there's what's called a life-changing event form. And this allows you to actually, based on your projected income or adjusted gross income for the current year, this year being 2025, retire in May, the rest of the year, you're receiving a lot less income. You have a lower bracket. If you lower your bracket just 1 or 2 levels, you fill out this life-changing form. You fill it out in 2025, you can fill it out again in 2026. You still take advantage of the opportunity to lower your bracket. We help people fax this form all across the country. CPAs and financial planners are always thrilled by this because it's a great value add to their clients. So the Medicare Savings Plan. This savings plan is actually underutilized. It's a state-administered program that helps with low-income beneficiary reduce healthcare costs. This basically helps with Part B premiums. So again, $185 for some people, and for some people, that Part B premium takes the bite out of their Social Security check, and they want to see if there's a chance to lower their costs for Part B. So there's a Medicare savings plan that exists. It automatically enrolls people in extra help. It helps with prescription drugs. In some states, New York, New Jersey, Connecticut being 3, there's no asset or resource test. Okay, but enrollment in MSP eliminates any Part B late enrollment penalty, even if later you lose your MSP coverage. So this is a great program. The income limits, again, these are just 3 states that I'm covering here. You can see that these income limits vary by individual and by couple. And these are low limits, but there are plenty of people who we work with who have these numbers and qualify and are incredibly grateful for the opportunity to get this MSP program that is actually, there's lots of money in the government to be able to support people with these low incomes. So how do you apply? You apply through the state Medicaid office. It requires a proof of income, Medicare and Social Security card, proof of the premiums, and proof of residency. So that's a simple process. It's often done best at the Medicaid office, but the truth is that there are other ways to apply, but that's really the easiest way to handle it. Prescription drug plans. The end of this webinar is going to talk a lot about how we can truly help you with prescription drug pricing and cost savings. In many ways, we are groundbreaking in this area. I hope you stick around for it. But there's extreme client sensitivity to these current and future potential expenses. When you have an Advantage plan, you're not paying anything additional for the Part D plan. You still have your copays. But then there are the standalones with the Medigap. And again, the prices vary tremendously. The annual deductible is $590 for 2025. but that's only for brand name medications. If you're on generic medications, you may never actually have to address this deductible. But for some people at the beginning of January, this deductible is high and is very impactful. The stages of drug costs have changed. The catastrophic cost for all medications in 2024 was $8,000. For 2025, it's $2,000. So these prices are changing yearly. I don't know what the future will be. And that $2,000 will inch up in 2026. But again, the maximum that someone can pay for prescription drug coverage, not including any standalone prescription drug premiums, is $2,000 for the year. For many people, that has been an absolute game changer. But there is also different prices for preferred pharmacies, standard pharmacies, mail order pharmacies. And there's discount options. People are very familiar with GoodRx. A new area is needy meds that I'll talk more about in future presentations. There's single care, there's pharmaceutical grants. There are people who are choosing not to get Part D. I never recommend that because there's a penalty if people don't get their Part D plan. But some of these Part D plans are as much as $40 a month and people are on no medications. So, this area is a great concern. So these are pricing for various pharmacies. You can see that the cost of the coverage varies. You can see based on the pharmacy, the prices vary as well. This is through Medicare.gov. This is through something called the Blue Button. We'll talk about this later. But this is how we solve your prescription drug costs challenge, is to actually enter things into Medicare.gov, which is actually something you can do with us, for us, to help you down the road with future pricing discounts. So, other pricing resources. I mentioned GoodRx. There's Mark Cuban, there's Amazon. Needy Meds is becoming more and more impactful, and you'll see more information about that. They actually have a Needy Meds discount card now. This Canadian store is not from Canada. It is a Florida-based company that truly has competitive prices. There's also international coverage that exists. All of those options are going to be available to all of our clients going forward. Extra help. This is, again, an expansion of low-income subsidy. It's extra help, it's low-income subsidy. It offers people with low income help with prescription drug costs. It helps with co-pays. What's changed is that the qualifications for extra help has changed, that it's an increase to 150% of the federal poverty level, which means that over 300,000 people will now go from partial benefits to full benefits. But this extra help program also has, in many cases, no deductible, in many cases, no premium, and fixed lower co-pays for some meds. So benefit trends. I'm always tracking benefit trends. I believe I am considered a thought leader in the industry, and I'm going to continue to provide you with this kind of information. But over-the-counter benefits really help a lot of people. They can go to their CVS or Walgreens and buy some over-the-counter benefits that some of these plans offer. In-home benefits. I'll talk more about some of the in-home benefits for home care that are available. Simplifying these benefits so it encourages more utilization. A lot of these benefits are offered in Med Advantage plans that aren't actually used. Mental health coverage is increasing in 2025. More mental health providers are being added each year, and they're really making a push to add more folks who take Medicare. Gym membership are undergoing changes so that people can actually participate more in at-home options. Dental benefits. They are provided under different Med Advantage plans. They are stable, and people really want them and expect them. So just to take a side step here, home health care. Home health care is really important. And there is now, always has been, help for the caregiver. And but the patient has to be enrolled in Medicare. It has to be medically necessary, and the caregiver has to meet Medicare requirements. Family members in this case, not in all cases that I'll mention, family and friends are excluded. The professional caregiver has to be a part of the Medicare program, but the doctor has to create a plan that explains how the caregiver will assist in the patient's health. Medicare must approve before they can receive any compensation. So what are some of these home health care benefits? This is 8 hours a day of intermittent part-time skilled nursing, up to 35 hours a week, but it includes physical therapy, occupational therapy, speech, home health services like bathing and dressing, durable medical equipment. Most home health agencies will accept Medicare, but they won't necessarily accommodate all medical needs. So 11 million people are eligible for home health services covered by Medicare. Thanks to helpful changes coming in 25, there's changes through a company called RubyWell. This population is homebound. Okay, that's a critical component, generally with health conditions considered chronic or complex, and must always have a caregiver. But families are struggling to find home care. As I think we all know, older adults want to be cared for at home, but caregivers want equitable compensation for it. They're taking time out of their job, out of their life, their family, their kids. And family caregivers are actually willing to get certified and are a solution in place that is available to be utilized through RubyWell. So 38 million caregivers provide more than 18 hours of unpaid care per week. That's an estimated $590 billion of unpaid labor. About 40% of family caregivers leave their jobs to provide care. What RubyWell does, and I've been very excited about this, they tap into the underutilized aspects of coverage so they can pay family caregivers a living wage. It provides home health agencies with a labor force of untapped sources of revenue. So this is a new initiative. It's by a team really of passionate people who I've gotten to know, who've experienced their own firsthand issues with family, friends, and loved ones. And it's really about supporting caregivers, enhancing it. And the reason that this is taking place is because of something called the JIMO settlement. Because this ensures that Medicare covers skilled nursing and therapy services, even if the patient is not expected to improve. This is the big issue. Coverage has always been known to only be covered when there is considered and documented improvement. This settlement agreement allows it if it's not expected to improve. Coverage applies when services are needed to maintain a patient's condition, preventing decline or slow deterioration. So denial of coverage is based on a lack of, it violates Medicare policy. Home health aides are covered when provided alongside skilled services and continue under the supervision of a care plan after the initial skilled takes place. So Medicare can't deny this coverage based on the absence of potential improvement. That's really important. Patients do not need to achieve full independence or return to their full level of function. So skilled care is necessary for those maintaining, preventing deterioration, and supervising home health aides who provide essential dependent care. What are those care areas? Complex wound care, physical therapy for mobility, some speech therapy for swallowing, ongoing supervision with home health. So what's the qualification and eligibility? Again, this is brand new, folks. And both of these statements must be true in a homebound status. The patient rarely leaves home, and when they do, it's only for short appointments. Leaving home is difficult due to shortness of breath, pain, or limited stamina. And one of these statements must also be true. The patient requires an assisted device, wheelchair, crutches, special transportation, or assistance leaving a home. And the doctor has recommended that they not leave home because of their condition. So, if Medicare can cover home health care, why aren't more home health agencies offering this benefit? There's a number of factors here. In 2013, Medicare covered skilled care to maintain an individual's condition or slow decline. But documentation and reauthorization process are labor intensive. Is the juice worth it? It's hard enough to find home health aides to staff these private shifts. Who will care for them? So, in order for the claims for the skilled care, they must include sufficient documentation, provides services are reasonable and necessary, the condition requires professional expertise, and unskilled caregivers cannot safely provide care independently. So beneficiaries have the right to appeal if services are denied under an incorrect application of GMO guidelines. Okay, moving on. Alzheimer's patients. Okay, does Medicare cover at-home Alzheimer's patients? The answer is, to some degree, yes. Medicare will cover home safety evaluations, cognitive assessments, care planning, and hospital stay, and of course, some prescription drugs. But there's a new program. It's called GUIDE. And the doctor may or care team may be participating in this new program. It's a new program for dementia care and support for caregivers. The goal of it is to improve the quality of life, enhance the support for caregivers, and help people living with dementia staying in their home. So this is about a comprehensive assessment plan, caregiver support, respite services for people who can get some respite outside of the home, coordination of meals and transportation with supporting and coordinating with clinical services, and a caregiver, 24/7 care team that's available. So just a quick story. 86-year-old woman living alone with dementia. She has regular appointments. Her caregiver is 35-year-old granddaughter who visits daily to help with housekeeping and personal care, and is a mom with a full-time job. So the challenge is Mildred is experiencing worsening symptoms. Her primary care doctor isn't equipped to treat dementia. She needs help getting to appointments, and Anne is just burnt out as a caregiver and wanted to find Mildred a nursing home, but it's too costly. Mildred learns about GUIDE from her doctor and starts working with an interdisciplinary team. Mildred's caregiver connects her to transportation services and gets caregiver training to cope with Mildred's symptoms. Mildred receives respite services, allowing Anne to take a break. These are new for moderate dementia. How to access them? Learn about GUIDE. Visit a doctor that's participating in GUIDE. These GUIDE programs are available through CMS, but patients must be enrolled in Medicare A and B and meet other eligibility requirements. So that's that piece. The other piece I want to talk about is hearing, the importance of really addressing hearing. Hearing loss is really a serious issue that's linked to loneliness, isolation, and depression. Many people really don't pay attention to their hearing at all, because hearing isn't just detecting sound, it's also about listening. It's about processing sound and understanding speech, especially in loud environments. I can't say that at my age, I'm not concerned about this. Those who suffer from hearing loss often struggle more with comprehension than volume. In the United States, 37 million people have some level of measurable hearing loss. 26 million more struggle with listening, despite regular testing. So there's a big stigma. Why do only 10% of people with hearing loss use hearing aids? Why the resistance? Because there's a stigma. 63% of millennials, 47% of Gen X, and 41% of boomers believe there's a stigma around hearing aids. The irony is 62% of Americans wear glasses, 45 million wear contacts, yet far fewer wear hearing aids. Millions use Invisalign for cosmetic dental correction. Hearing aids should be seen as normal and not shameful. So there's custom versus over the counter. The custom hearing aids by far offer better noise reduction and personalization, but it requires professional expertise and precise manufacturing. There's over the counter options, but they lack the same level of effectiveness in treating hearing loss. But I have to say, AARP members receive free hearing exams, up to 3 professional visits per year, $2,000 of average savings on hearing aids for most, not all, major brands, and a 4-year warranty. And there's a phone number for those who are on AARP, maybe a med supplement plan. Some takeaways on hearing health awareness. Hearing loss really must be taken as seriously as vision and dental. Public education and funding really is needed for the prevention and treatment, but wearing hearing aids is a sign of self-care, not a weakness. Even on The Golden Bachelor, the hearing aids were worn with pride. Hearing is not just about sound, it's about connection, engagement with your loved ones, and living life to the fullest. I work with a couple of folks here locally that are great audiologists. So a myth, you don't need a hearing test until you notice severe loss. Regular hearing tests can detect gradual loss, which can be managed. Hearing aids improve hearing by amplifying sounds, but they do not restore natural healing. Untreated hearing loss is linked to several comorbidities, including cognitive decline, depression, and increased risk of fall. Managing hearing loss can improve communication, mental health, and safety while positively impacting. Part B does not cover hearing aids. It does cover diagnostic. There's various price ranges, but they last a lot of years. And there are some plans that offer partial coverage. So get evaluated, get a hearing test, go to an audiologist, not just an ENT, but an audiologist. Even though you pass the hearing test, you still may struggle with comprehension in real world environments. Proper treatment should focus on speech comprehension, not just detecting sounds. And then there's Care Credit that offers financing for hearing aids, just like it does with dental and vision. But I will say this, that's interesting. Even in countries with subsidies and or paying for it, hearing aid adoption is still only 40%. Dental. Dental coverage, 77% of people say they plan to visit the dentist in the given year, only 37% do. Some people consider it critical, some people consider it non-essential. You can't be healthy with sound oral health. Poor oral health affects your physical and mental well-being. 1 in 6 adults have untreated tooth decay. 2/3 have gum disease. 1 in 5 adults delayed or skipped dental care in the last 2 years. About 47% of adults retain their dental coverage at age 65 post-employment. ER visits for preventable oral health issues have surged. Many states have excess dental capacity. But it's all fee for service. There's a high proportion of dental costs that do come out of pocket compared to medical health. 1 in 5 spend over $1,000, 11% over $2,000 a year for dental costs. Costs is the top reason people don't frequently visit their dentist, including high-income earners. These dentists have discount plans in their office for $200 to $300 a year, and then you get a 10 to 30% discount. But there's a process if you're going to get more than 2 cleanings a year. Advantage plans don't offer the same benefits. It's okay to ask your dentist for a cash discount. Your dentist can be helpful in controlling expenses. But after leaving a job, you might be able to keep your dental through COBRA. And if any of you have an HSA account, use it for dental. Preventative, often 2 exams a year, 2 cleanings a year. But the major restorative side of this screen, that's where you're only covered at 50%. So if a crown or an implant or a bridge costs $1,000, you're paying $500, the insurance company is paying $500. There's also sometimes a waiting period. Advantage plans have no waiting period. They're not a lot of coverage, but there's some. But these standalone plans, some of them have a waiting period for some of these comprehensive services. So access to weight loss drugs, that's become a very big issue, right? These Ozempics, Mounjaros, when prescribed for type 2 diabetes, it's still about the doctor providing documentation to validate the need for them, okay? So a lot of folks I work with can't get this kind of coverage. But more and more, some of these these prescription drug coverage are being covered under sleep apnea, some of them for cardiovascular issues. Some of them are beginning to be covered. I spoke to a cardiologist issues. There's a lot of paperwork, a lot of documentation, but more and more of them are being covered. If it is covered, again, the maximum out-of-pocket costs are $2,000 for prescription drugs. So that's the maximum that can be paid. Mental health professionals, okay? They're adding counselors and therapists all through the network. There are 400,000 behavioral health clinics nationwide that are eligible to serve Medicare beneficiaries. So people need to verify their mental health provider accepts Medicare. Improve participation may improve access, reduce waiting times, but this is an expansion. Same with telehealth. There's some discussion that telehealth will be taken off the docket for the current administration. I don't know. I will keep informed. So, there's an importance of understanding your potential costs, recognizing the importance and the integration of healthcare costs and financial planning. But my staff always speaks about advocating and appealing. 80% of the people don't appeal or advocate for themselves. They can't. They don't have the time, the energy, or somebody to help them. Of the people that advocate and appeal, a large percentage wins the appeal. But seek objective information. Discuss the changes during the open enrollment period. Decisions at age 65 and retirement are important. Look at your doctors and meds. Understand these Advantage plans and Medigap plans. Ask questions. Find a trusted resource. We hope to be your trusted resource. We're unbiased. We're always going to provide you with education. We provide you with webinars and seminars. Things change. They're always changing throughout the year. So now what I want to attempt to do is play. So I'm going to ask, can you hear it? Yes? It's working. Okay. Hello, I'm Mark Brownstein, the principal agent at Emerald Medicare. Our team at Emerald Medicare is always looking for ways to make your Medicare experience better and more efficient. That's why we've partnered with RxCare, a secure online AI platform that simplifies your drug and doctor reviews and offers opportunities for drug cost savings throughout the year. RxCare securely connects you so you can complete many important Medicare forms online. Once connected to this platform, you can personally update your information to find the lowest cost Part D plans for your medications. This will allow for a quick turnaround time, particularly during open enrollment, which is the busiest and most demanding time of the year for clients that are changing drug and doctor information. Our goal is to make this process easier and more efficient for both of us, while helping you save money on your medications. So please listen to the next few minutes of this video as we walk you through how RxCare makes this process simple. guiding you towards the most appropriate coverage through your association with Emerald Medicare. With changing rules in place, Medicare requires a scope of appointment, or SOA, before we discuss Medicare plans with you. A permission to contact form is also required before we can reach out to you about your options for Medicare plans. These are federal rules that protect your privacy and ensure you're only contacted by Emerald when you choose. This short tutorial guides you through completing your scope of appointment form with RxCare. This form is required before we can discuss your plan options. It ensures compliance and protects you as a beneficiary. The first thing that will happen is you'll receive an email in your inbox. It's not coming from Emerald Medicare. It's coming from RxCare. You see on the top line there, it says scope of appointment. Click on that. There's a lot of spam, so look in your spam box on occasion. You will see something that says complete the scope of appointment on this red button. This will take you to the Secure Rx website where you'll actually complete this form. Then you'll click the box on the areas that you would like us to support you in, followed by your name, your address, your phone number, your zip code, and then that you are the authorized representative to act on your behalf. And then you'll type in your name to make sure that you are the beneficiary that we are working with and looking to support. You will click Submit Form, and this confirms that you have submitted the scope of appointment. Thank you so much for participating. Welcome to this quick tutorial on completing the permission to contact. This allows us as the agent to contact you about your Medicare Part D plan. So you will get an email as well here. You will click on that RX consent form, consent to connect. That red button will move forward, and this will give us the opportunity to look at plan updates, cost savings opportunities. You will then let us know how you want to be communicated by us. You will basically put your name on this form, understanding that this is a consent, but it's voluntary, and it can be withdrawn at any time. You click the Submit Form button, and you have now completed the consent to contact. I thank you so much for your participation in this next step of Emerald Medicare. At Emerald Medicare, we want to make reviewing your Medicare plan choices as simple and accurate as possible. RxCare helps us collect your prescription drug list directly from Medicare.gov using a feature called Blue Button. When you connect your Medicare.gov account through RxCare, we can securely pull your last 12 months of prescription drug claims directly from the Center for Medicare Services, CMS. This means you don't have to manually list every medication during the year if your meds change. RxCare initiates that import for you. Our team at Emerald Medicare doesn't rely on this data alone. However, once your medication list is in RxCare, we will call you to confirm that everything is correct before we move forward. This is yet another quick tutorial walking you through how to securely connect your Medicare.gov to RxCare. By doing this, RxCare can electronically retrieve your last 12 months of prescription medications provided by CMS. You will get an email, connect to Medicare.gov. Again, look in spam, it's not coming from Emerald Medicare. You will click on that, and then again, you will see another red button that says log on to Medicare.gov. This takes you directly to Medicare's official website We use this all the time, every day, and we have for years. It is an incredibly valuable and secure site. You will then enter your username and password. If you don't remember it, you can get your password. If you've never logged in before, you can create an account. This is all secure information. After logging in, however, well, what this does is allows us to sort of look at doctor visits and hospital visits, but it's really about your personal information so that we can get access to your name, address, your date of birth. If you click the connect button, which is incredibly valuable, and you will see more over time how valuable this is for you. This is just the tip of the iceberg on what's possible as all of you engage in this process. You will see this confirmation email that prescriptions have been shared successfully, and we are going to be able to discuss with you which drugs you use most often and what costs there are and what's the best fit for you. This is the last video. Your personalized RX Care link, or Pearl, gives you secure access to manage your Medicare review in one place. Using this Pearl, you can update your personal profile and plan information so we can serve you better and offer better overall Medicare recommendations. You can also manage your provider details, drugs and pharmacies, so we have the most up-to-date information. If your income or public assistance status has changed, you can update it here to check if you qualify for additional savings. This secure platform makes it easy to review and update your details quickly. This last video will guide you through connecting to your personalized RX Care, where you can review your updated prescription drugs, your provider and profile information. Completing this process amazingly ensures you receive the best Part D prescription drug medications. Let's get started. So you'll receive an email from, in this case, Emerald Medicare, with a secure link to your personalized RX Care profile. Click the link and open your personalized page. This link is for you and you alone to allow you to update and verify your information. There's a privacy. You have 30 minutes in which to use this code. Once you click here, you can see that you can update your information. This information is your name, your address, your date of birth, your income, your smoking status, your Medicare beneficiary number. All of this information is really helpful in many ways. Again, you will see the benefit and the impact of this over time. So again, thank you for participating. Now we're looking at what plan is right for you. Here we have the plan that you are on, and if this isn't correct, you'll correct it. If this isn't the plan, then you can click next, and you can update the plan. Now we're at pharmacies. Again, amazing. You can actually type in the pharmacy that may not be listed for you. Type in the pharmacy. It's within a radius of where you live, your zip code. You look for the pharmacy. You click on the pharmacy that you use. You click next, and it is now part of your profile forever. You can delete and come in here. Next, you're updating your medications. You want to add a medication. You see that the 2 medications listed were the 2 medications you're on, but now you have a new one. This new medication can now be added by simply typing in a few letters of this prescription. You adjust the quantity, you adjust the frequency, and you quickly add, and it is now in the system for us to help you with your prescription drug costs. Then we go to doctors. The doctors that are listed that we have for you on file, but you're adding a doctor. We're typing in the first few letters within your zip code. We're looking for a particular doctor, and we find the doctor that we're looking for. We scroll down a little ways and we see the doctor, and maybe we want to add this as the primary doctor because you want to make sure that we know that it's your primary doctor. We click primary doctor, and then we click next, and everything is entered. Now we're talking about assistance with Part B, assistance with extra help and low income subsidy. So based on your income and your assets, we can further help you. You go through this information. If you want, you click submit, finish. This information is now updated successfully. And then you can simply say, talk to agent. And then my contact information, our phone number, our office is all right there for you. So at Emerald Medicare, our goal is to make your Medicare experience as simple and valuable as possible. By trusting us to get started using RxCare, you're taking an important step towards not just engaging in this cutting-edge technology, but being able to continuously find the best coverage for your needs. If you have any questions or need assistance getting started, don't hesitate to reach out. We're here to help you every step of the way. These videos will be available on our website shortly to review. Thank you all so much for participating in this groundbreaking webinar that has taken an incredible number of hours to produce. I hope you got value, and I look forward to working with all of you in the future. Thank you so much. Have a nice evening, and we will all speak soon, I hope. Tell your friends, tell your neighbors. We're here to help. We have an amazing team. Thank you again. Be safe, be healthy.